Yeah.
Thanks, Danielle. Hi, everybody. This is Amy Brower from NBSTRN. Welcome to the National Pilot Call. This is October 2019. We always start out with a welcome to everybody and give anyone who is new on the phone and would like to introduce themselves or their team the chance to do that. And then we start out with an update from the states and teams who were funded by NICHD to conduct some implementation pilots. So with that, we always include the previous month's report in red, just as a little bit of context. And then I take notes during the call just to keep track of the numbers and to see if there's anything that the states and pilot sites are finding about the implementation of these conditions that you all want to talk about. So feel free to unmute yourselves or use the chat window if you want to ask a question of each of the states that are reporting. And with that, I'll turn it over to the New York team to see if they want to give us an update on what they've been up to.
Hello all, it's Joe from New York. Just a quick update. We've had no NPS1 referrals since last month, so we're still at 16. We did have 5 that went for molecular test, second-tier molecular testing. All 5 had pseudodeficiencies. For SMA, we've had no new cases since the last call. And then for Pompeii, we had 2 new cases, so we're up to 153 referrals. One was determined to be a carrier via molecular testing. We refer those, as I probably mentioned or we've mentioned in the past, just because we don't want to be depend our life on, or that child's life on our molecular testing. There's always a possibility we'll miss something, so our process is to refer if we find any variants that are a boost or known disease-causing variants. And then we also found the other child had 2 likely pathogenic variants, both of which were associated with late-onset Pompe disease. And then, let's see, I have the total numbers screened. If you need those, we're up to 1.31 million or so for Pompe. And for NPS1, we have 264,000 approximately screened. And I don't have the SMA numbers for number screened, but it'll be almost a year, or it is maybe a year, I think, as of October 1st. So we're somewhere in the 230, 240. It should be actually the same number as NPS1 since we started at the same time. And those are samples tested, not necessarily newborns in this case, these cases. And then ALD, we have, I didn't give you the updates on those, but we're up to 1.5 million screens. We've had 100 total referrals, so what is that? I think it's up by maybe 1 from the last time. Yeah, 2 since the last time. And looks like one of those, no, both of them were males, no females detected in the past month. That's the New York update. We did get approval to start using our second-tier biochemical testing for Pompe disease. So we're looking at what Mayo had published with creatine and creatinine. And we'll be collecting the data here shortly, but we will still need to work out how we're going to work that data into, use CLEAR with that data. We haven't gotten very far with that. We're going to check and see how well it will work without CLEAR, but I think we're probably just going to have to bite the bullet and work to get that into the system. So, Carol, if you're on the line, I hope to work with you on that shortly.
Any questions for Joe? So Joe, when you say you're implementing the CLEAR tool, or maybe not, that you're doing the second tier biochemical for Pompeii using the method that the Mayo team published, but does that mean you're going to use the CLEAR tool, or you're still trying to implement?
We would like to use the CLEAR tool for it because I think that's, the best way that it will work, because it takes into more than just the ratio and the enzyme activity, but other factors as well. So combined, like age and birth weight, things like that will all contribute to the way it works. And the other enzymes as well. So all together, it works as a package.
Okay. Any questions for New York? Okay. Let's see. Last time we talked a little bit, Joe, about your SMN2 copy number. I think there was a question from Stan from California about how you guys were doing the sequencing for SMA. And then Dr. Gelb, you guys talked a little bit about the molecular side of MPS1. And I think both NBSTRN and New Steps offered to, still collect your methodologies and algorithms for any of the state programs and push those out to the websites if it helps anybody as far as implementation of those conditions. So is anybody on the line from Georgia?
Yeah, it's Angela. I'm here.
Hey, hi, Angela.
Hey. So SMA update, as of the end of September, we have screened 96,045 specimens. We are in our total case of diagnosed, or total numbers of diagnosed cases, we have one type 0, two kids that September was a busy month for us. We got 2 kids with type 1 SMA this past month. I always joke, from my labor and delivery days, kids don't like to do things alone, so they always come in little groups. So we had 4 kids show up in September. So 2 with type 1, that 1 child with type 2, that was known previously. And then we have 2 twins. This is kind of heartbreaking. 2 twins with SMA. They're preemies in the NICU right now. We don't know what type they have as of this point, but we do know that they have 3 copies of SMN2. So they are in the NICU waiting for discharge to be followed clinically by neurology, but they are aware of that kiddo, or those kiddos. We also have 1 more cooking. We just got a referral or a screen yesterday from the state lab that looks like it's going to be real, another with no count on the SMA. So September and the beginning of October are a busy month for SMA after a kind of slow start. So that's where we're at.
So Angela, can you remind me, or do you guys know where those cases are getting treated? We're doing that data collection effort with Dr. Swoboda and her team, and I know Ren from her team is on the line. And it sounds like they're getting referrals from other states for the treatment side of things. I was just kind of curious if you guys have a window into where families or newborns are going for treatment.
Yeah, absolutely. So, well, I know, the type 0 kiddo obviously was getting nothing, just supportive care. The kiddo with type 2 that was diagnosed early on in the project, that family went to Boston for gene therapy. I know that. That was earlier in the year. And then everybody else is sort of in the decision process. Like they've just, literally in the past couple weeks, we were sending handfuls of kiddos to neurology. So I know that our children's neurology team here in Atlanta does nusinersen treatment for type 1 and I think type 2. I can't remember about type 3 or not. And then we are not doing gene therapy here at Children's at this time. But I recently found out from anyway, the UAB, University of Alabama in Birmingham, is doing gene therapy. So I wouldn't be surprised. I think it's all going to depend on insurance, but I wouldn't be surprised if more and more families are just being farmed out to other sites for gene therapy, if that's what they choose to do. But I don't know at this time because they're all so fresh.
Gotcha. Thank you.
Yeah, no
any
problem.
questions for Angela and the Georgia team? Are you guys starting any additional pilots?
Yeah, I was just going to say, thank you for that segue. I was just going to say that we did also get the award from NICHD to do the pilot for proximal urea cycle disorders. So that contract was enacted at the beginning of September, and we are working on getting all those pieces into place. So we won't be doing any testing methodology changes. We're just using the analytes that we already have and then plugging them into the CLEAR tool. So at this time, it's going to be a little funky. We still use the neobase type 1, so we don't get glutamate and glutamine on in our results. So we're customizing the CLEAR tool to make our own for the analytes that we have, which we think will be a decent start. But our lab is just getting ready to switch to neobase 2, which will give us those other analytes. And so then we'll probably switch tools as soon as we can, once we can take a look at all that data and make sure it's reasonable and get things where we need it to be, and then switch over to the large national CLEAR tool for that. So so we're still getting all the pieces together, but we're really hoping, assuming that Emory IRB gives me approval soon, I'm crossing my fingers, that we will get started live screening by the end of the month.
And that is it is a live trial, right?
Right, yeah, just like these. We'll be doing everybody, we'll be running everybody's results. The big concern for us will just be the timeliness piece of it. So because we have to get all those results, and then the tool will actually be run after the results are sent to us here at Emory in the follow-up program. It won't be done at the lab, so I'm just a little concerned about the timeliness piece of that. But I think it'll be a good learning opportunity to see how fast we can get things going. And also, we have a few grant proposals in play and contracts being placed with people, so that hopefully we can start using the CLEAR tool on the back end over at the lab side for a number of different things. And obviously, PUCDs would be ideal for that as well. So we'll just see.
Great. Is that the usual 80,000 bursts 2 years, or
the contract?
Yeah, or yeah.
So we have been given a contract to screen for a full year, so about 130,000 samples for us.
Okay, gotcha. Great, thank you.
Yeah, no
any
problem.
questions for Angela? Great. We'll look forward to your reports on that new pilot. Good luck.
Yeah, I'll definitely keep you guys updated, but we're excited about it. So thanks.
That's great. North Carolina?
Hey, Amy, this is Blake.
Hi, Blake.
Hi, how's it going? Update from last time, we're still only screened 4,700 approximately. We're still pushing forward with new recruitment methods to up our recruitment into early check, which would in effect be screening for SMA. So we're hopeful in the next few months we see an increase with these new recruitment methods that we're implementing in the state to get more consents into the early check program and into the SMA pilot.
Great. Are you guys also going to do the same new pilot that Georgia's doing, or is it just one site?
We did not end up submitting a proposal to NICHD for that new task order.
Okay, so this SMA is the pilot you guys have going on for now.
That's correct.
Okay, great. Any questions for Blake and the North Carolina team? Okay, let's see. Oh, got one thing in the chat window. Let me just check. I always forget the North Carolina birth weight. Is that, oh, what's your,
we have roughly,
yeah.
We have roughly about 10,000 a month. So about 120,000 a year in North Carolina.
Okay. That was from your pals in Michigan. I was curious. Wisconsin? I know last month Dr. Baker couldn't join. I don't see her online today either, so we'll catch up with them when they're able to join. So last time we also got an update from Texas, Massachusetts on the clinical side, and Nebraska. Are there any states other than the ones that we just ran through who would like to give us an update this month?
Hi, this is Kansas.
Hi, Kansas.
I'd just like to say hi. We are planning on starting our piloting in November. We've got new instruments in, and we're going to be piloting with our new instrument.
What are you starting to pilot?
Sorry, SMA.
Oh, gotcha. Good. Thank you. Will you remind us where you guys are at with Pompeii, NBS1, and XALD?
So we had already, our issue was deciding the method. We had decided we were going to go with Baby Seeker. When we had our advisory council meeting, 2 of our specialists asked us to look again at mass spec, and we did. And we went ahead and we have decided that we are going to go ahead with babies. And they actually, Candace Brennan flew into our advisory council meeting and talked to our specialists. So that's where we're moving forward with that. We hope to be starting, getting that validation started first quarter 2020.
Oh, great. And will that be for all 3 of those?
Well, we are going to be, they don't want us to do all 4 because all 4 are not on the RUSP, you know, the NPS1, Pompeii, Fabry, and Gaucher.
Ah, gotcha.
So we are looking at doing Pompeii and NPS1 and using Fabry and Gaucher as a confirmation, and then sending out for a second tier.
Gotcha. So you won't be reporting Fabry and Gaucher.
Mm-hmm.
Gotcha. Okay.
Okay.
Thank you. Any questions? What approach are you guys using for SMA?
We're using the CDC, and we were running on Agilent, and that's what we're running on now, but we've been running into some problems with our Agilent instruments. So we've gotten grants, and we're purchasing the QuantStudio 7s.
Will you remind me if the CDC method is bundled with SCID, or is it a separate assay? Okay.
Yeah, it's the SCID SMA multiplex.
Gotcha. Thank you.
Thanks.
Any questions for Kansas? Okay, thank you. Any other states that would like to tell us what's going on?
Amy, Ann's on the phone from Massachusetts.
Yeah, hi, Ann.
Hi. I have a brief summary. So far, we have screened about 100,000 babies for all 4 of the disorders. For Pompeii, about 32 of them have gone to sequencing. We have 1 that had a prenatal diagnosis, and 2 that have two pathogenic mutations but are still being worked up. For MPS1, another 32 of them went to sequencing for IDUA, and 1 of them has a firm diagnosis of MPS1. We've recently changed our referral to sequencing, so I think fewer babies will be sequenced for Pompeii and MPS1. For XALD, of 100,000, 17 went to sequencing. We have 4 XALD diagnoses and 2 Zellwegers. that's pretty much, those are approximate numbers because that's not the section that I oversee. So I'm kind of running by the seat of my pants on those. Rather, I oversee the sequencing, but as far as the clinical, I'm not completely sure of the final diagnoses. For SMA, Massachusetts is one of the only ones that we're doing still a singleplex, rather SMA with just a housekeeping internal control. We have screened 100,000 babies. We have only referred 5 babies for diagnostic workup, and the first of the 5 was the famous false positive due to an inhibitor. The other 4 that we referred all have SMA. One of the babies appears to have 4 copies of SMN2. That was a surprise baby. One of the baby, all of the other babies only have 2 copies of SMN2. One of them was a prenatal diagnosis. Another one was known to have carrier parents, but the baby wasn't known to have SMA until the newborn screen. And the third one was also a surprise. So we are running at about 1 in 25,000 for SMA. 3 of the babies, we have indications that they are being treated. I think the baby with the 4 copies of SMN2, my understanding that baby is being monitored, but I don't have any updates on whether or not that baby is actually being treated. And that's it from Massachusetts.
Thanks, Dr. Cuomo. Can you remind us how you guys do the sequencing? Is it like Sanger sequencing of the target gene, or what are you guys doing?
For the LSDs and XALD?
Yeah.
The sequencing is, that's Sanger sequencing.
Okay. Thank you. Any questions for Dr. Cuomo and her team at Massachusetts?
Hi, Ann, it's Joe. Can you hear me?
Hi, Joe.
I was wondering, you said you had an NPS 1 confirmed. Was this the child or the early onset version, classic onset version?
So I don't know what it is. I hesitate as to what Neela has told you. So this is a baby who had other congenital anomalies. Is that the one that we're talking about? Are we talking
No,
about
I actually hadn't heard about this one, so I was just curious how was a severe MPS 1 and how low the activity was. Because you said I was changing algorithm, so I wasn't sure what maybe you were doing for that.
Yeah, the algorithm really, the algorithm change really had more of an effect on the activities that were at the higher end, not so much at the low end. This baby had only 2% IDUA activity.
Is that at the mean or the median?
Oh God, I don't know,
That's
Joe.
okay. You don't know. They're pretty close, actually. I see. Yeah.
Yeah. And Neela, unfortunately, is out of the country, but she'll be back, I think,
so
next week. So why don't you follow up with her?
Okay. Yeah. Thanks.
And this is Debbie Friedenberg. I don't know if you can hear me or not, if I'm still muted.
Yep.
So
no,
do you have a feel for how many of the parents are getting prenatal carrier screening for the lysosomal storage disease?
How many? I don't. I do have a I do know that when we began screening for both Pompeii and SMA, and our numbers were really low. We looked at the kinds of prenatal tests that were being offered in Massachusetts, and the council panel did have Pompeii and SMA on the panel, but didn't have MPS 1 or XALD. Massachusetts doesn't track percentages of parents getting prenatal testing, but I do think, I mean, from the very beginning when we had lower frequencies than some of the other states, that was one of our first speculations, was that parents were getting prenatal testing and taking action.
Thanks.
So just so I got it right, Debbie, so your question was what percentage are getting prenatal testing?
Right. So we get calls all the time on various conditions where parents have been identified as carriers, and usually they're calling to ask us to expedite the newborn screen on the kid, and we can't do that. I mean, we'll track them. Or in the case of cystic fibrosis, when the IRTs are normal, if the parents are known carriers, they ask us to reflex it to DNA in the face of our normal IRTs. And because we know we missed some folks on CF, we always do that. And so I was wondering, you know, both on incidence numbers, but also whether there was any pressure on the programs as parents were being identified as carriers.
Interesting.
Yeah, it's interesting, Debbie. For CF, we reported a long time ago, you may remember that in Massachusetts, that we were seeing about 30 babies born a year with CF. And as soon as ACOG came out with recommendations for CF newborn screening, prenatal screening,
right.
Our numbers dropped in half. And they not only dropped in half, but the babies that were missing were the Delta 508 homozygotes. And those were that was the screen that was being offered prenatally. In Massachusetts, it's going to very much depend on the disorder, but for CF, if we get a call for trying to expedite a CF newborn screen and parents are carriers, our recommendation is that that baby, if both parents are carriers, our recommendation is that the baby have a sweat test and that they not rely on the newborn screen. And
And we do that as well, but they ask us to reflex it to DNA in the face of a normal analyte value, which we do all the time for CF.
Yeah. Mm-hmm.
But I didn't know if that was going to carry through to the lysosomal storage diseases as well.
Mm-hmm.
Thank you. Any other questions for Dr. Como? Okay. Any other states that want to give us an update?
Hi, Dr. Brower. This is Kim Piper in Iowa.
Hi, Kim.
Hello. I would just like to let the group know that Iowa is starting to ramp up for an SMA pilot. We are in the process. We've received administrative approval to do a pilot. We've put a budget together. We're in the process of starting to set up our algorithms, get the necessary lab equipment and infrastructure in place. And then we've identified specialty care providers for referrals. And we're working on our IT side and our educational materials. And we plan on starting the actual testing for SMA for the pilot in July of 2020, with an anticipated completion of the pilot by July 2021.
Great.
Kim, what method are you guys using?
I cannot tell you that. I don't know. Sorry.
Maybe next month. I'll try to wait.
Right. Yeah. Yep. Okay.
Okay. In Iowa, do you guys have one referral place, or do you have a few that you've identified?
We just have one, and it's at our neuromuscular clinic at the University of Iowa.
Okay.
They currently take care of SMA patients.
Okay. That's at your children's hospital?
One of the children's hospital, yes.
Ah, gotcha. Okay, thank you. Any questions for Kim and her team from Iowa? Okay. Any other states that want to give us an update, or anybody else on the line that has a topic they'd like to discuss? Let's see. I know we heard from Dean last month a little bit about the Newborn Screening Saves Lives Act. I don't know if, I know it hasn't passed yet, but I don't know if anybody has any updates on language or anything that you're hearing on the streets of Washington.
Yeah, this is Dean again. Yeah, you're correct. It has not passed. It has been introduced into the Senate, which is an incremental progress. And my understanding is and I don't know all the legal details of this, but the funding apparently is in place here that covers us through the end of the year. Although we saw the advisory committee pull in their November meeting into September, so it was in last fiscal year. I am not aware of major amendments that are being proposed, but the general issue in the Senate is that there was a request to increase funding to launch new screens, support for states for new screens, and so I suspect that the financial side is the primary objection. There's also, and I think I mentioned this, well, it's not in your notes, but there also is a concern that dried blood spots and retention and privacy and those sorts of issues will be added back in as an amendment. We went through this whole rigmarole with the common rule and those revisions in the past 3 or 4 years, and so that's another pending issue.
This is Debbie Friedenberg, and about 5 minutes ago, we got an email from Catherine Riley that said all activities on ACTUNC have stopped. All official business related to congressionally established ACTUNC, including workgroup activities, is halted at this time, and that they're exploring options to continue the work.
Okay, and I wouldn't disagree with that. Hopefully this gets resolved, in the next month or two, and that allows them to resume with their next meeting, which I think is February.
Do you know, Dean, I know it's hard to say, but are the dry blood spot, last time with I guess, provision that anything collected after a certain period of time had to have consent attached to them to do research. Is that still the idea, or do you know what's going to be added back in potentially about dry blood spots?
I have not heard the specifics. It's just generally this whole issue of privacy and retention.
Gotcha.
And research on the spots, as you pointed out.
Okay. Thanks for the update, guys. Any questions for Dean or Dr. Friedenberg? Okay. The New Steps team is tied up this afternoon, so I get to give their update. I should have thought of something exciting to put in there, but they're going to be, I guess this is exciting, they're going to be issuing a funding announcement for SMA implementation next week, so they want you all to keep an eye out for that. And they wanted to remind us all that their implementation maps and reports are routinely updated on newsteps.org. So if you want to track the implementation of XALD, MPS1, Pompe, SMA, and any of the other conditions that might be part of pilots, you can check out their website. For NBSTRN, we were just at a meeting with several of you guys last week, at the University of Minnesota, focused on MPS 1. So I know I learned a lot from everybody. So it was a really great meeting, and I think talking through a lot of the issues related to MPS 1 screening and whether we were doing enough to track outcomes and to help families find care and support throughout the process of screening and diagnosis. We just had a little bit of a article in the Rare Disease Supplement that was part of USA Today, so you can take a look at that. We wanted to announce that New York State just began 2 days ago a pilot of Duchenne muscular dystrophy. We're helping out a little bit on that pilot on the data collection and analysis side, so it's going to be one of our first times to begin to look at building the evidence base for a nomination, hopefully to the advisory committee as it gets back into swing. It's scheduled to be a 2-year pilot. 100,000 enrollment is the target in 11 hospitals in and around New York City. So I don't know if anybody from that part of your team, Joe, is on, or if you guys wanted to say anything more about that Duchenne pilot.
All I know is just what you announced, that we started it this week. We got our first few samples, I think, Tuesday, and so far I'm not hearing anything bad is going on, so must be going according to plan.
Yeah, nothing bad.
Hi, this is Norma.
Oh, hi, Norma.
Thanks, Joe. Yeah, we've been receiving specimens for the past 3 days. They're consented, obviously. We've been testing them. We haven't had any positives or borderlines yet, but fingers crossed things are going well so far.
Oh, good, good. Thanks, Norma.
You're welcome.
Will you remind everybody what the methodology is for screening?
So PerkinElmer has developed a test measuring creatine kinase, the muscular isoform. It's a fluoroimmunoassay, very similar to the other GSP assays that they have for T4, TSH, IRT, 17-OHP, etc. It's not yet FDA approved, but they have submitted it for FDA approval. So we did validate it in-house. We tested approximately 9,000 specimens that were blinded, and we've come up with our own cutoffs for the assay, and that's the methodology.
Great. Thanks, Norma. Any questions for Norma?
So this is Debbie, but it's not actually a question. I just wanted to let you know that the APHL SMA funding opportunity is already opened. It opened yesterday.
Oh, good. You're even more up to date than I am. It's no surprise, Dr. Friedenberg.
They show up in my email.
Oh, that's cool. Good. That's exciting. What do you remember what the funding does or what it's for?
It says newborn screening state programs can use, or it says newborn screening programs can use funding for following expenses associated with SMA screening implementation, but the list is not comprehensive. Lab equipment, pilot testing of SMA procedures, technical assistance for implementation or follow-up program protocols and meetings and trainings.
Oh, cool. Great. Thank you.
Sure.
Okay. Anything else anybody would like to talk about today? With 69 of your best friends on the line? Okay. So we have this call the first Thursday of each month at 2 p.m. Feel free to send us any ideas. I know we've spent some of the calls, giving an overview of things like ClinGen, ClinVar. We've gotten a few requests to do more lecture types like that on particular topics, especially on follow-up algorithms and health outcomes. So we'll be working with some of the clinicians who routinely call in and who are part of some of our long-term follow-up efforts at NBSTRN to schedule some of those in the new year. But before then, if you have any ideas for us, feel free to reach out. We're more than happy to accommodate any ideas or foster any questions that you guys might have. Sorry, I've got the chat window. Let's see. Oh, okay. Okay. So Kate, we at NBSTRN, Kate told us, asked, where can you find the notes about the call? I swear I have to get better at making sure I give those to Danielle for her to post. So we have a YouTube channel where you can listen to the call, but we should be able to send out these slides to anybody for the last several months that we've been keeping track of them. We're working on a new website that hopefully will launch soon, and then all of the information will be contained in the website on a monthly basis, so it'll all be easy for you to access. But right now, if you need anything from us, feel free to reach out individually, but I'll make sure that I send these right away to Danielle, and she can send them out through the APHL listserv, and then also the link to the YouTube channel. Anything else that we can do or help with? Okay, thanks everybody for your time today, and feel free to reach out to us. Have a great rest of your day. Take care.
Thank you.